This lecture covers the topic of allergic reaction or anaphylactic reaction. I will use these two terms interchangeably. This lecture will briefly cover the different classifications of an allergic reaction based on the Gell and Coombs classification system of drug reactions. We will also review the 3 different criteria for diagnosis, as well as the signs, symptoms, and risk factors for an allergic reaction. Lastly, we will review the treatment of an allergic reaction. These are abbreviations I will use throughout the lecture. You can refer back to the slide as needed. There are 4 types of allergic reaction. The one we will focus on for this lecture is the type 1 reaction. The primary clinical difference between this type of allergic reaction and others is the time of onset of symptoms after exposure to the causative agent. The pathophysiology of a type 1 reaction is that it is mediated by immunoglobulin E, whereas the other, slower types of allergic reactions are primarily mediated by IgG, IgM, IgA, or T cells. Based on the allergen, you can predict the type of allergic reaction the patient will have. Some examples of allergens that would likely cause a type 1 reaction are latex, vaccines, and blood products. The World Health Organization recommends classifying allergic drug reactions into immediate and delayed onset reactions, which would group types 2, 3, and 4 into one category. Types 1 and 4 are the most common seen types of allergic reaction in clinical practice. The pathophysiology of a type 1 allergic reaction is that the allergen or drug binds to an IgE antibody that is already bound to a receptor site on mast cells or basophils. This interaction then causes the rapid release of potent vasoactive and inflammatory mediators from the mast cell or basophil. There are 3 different criteria a patient can meet to be considered to have an anaphylactic reaction. The first criteria includes an onset of illness involving the skin, mucosal tissue, or both, and either respiratory compromise or reduced blood pressure or other signs or symptoms of end organ dysfunction. Involvement of the skin and mucosal tissue means that things such as generalized hives, itching, flushing, swollen lips, tongue, etc. Respiratory compromise is symptoms such as dyspnea, wheezing, bronchospasm, stridor, reduced peak expiratory flow, hypoxemia, and others. The second criteria requires 2 symptoms from the following after exposure to a likely allergen for that patient: involvement of skin mucosal tissue, respiratory compromise, reduced blood pressure or associated signs and symptoms, or persistent gastrointestinal symptoms and signs. Common blood pressure related symptoms would include syncope, hypotonia, incontinence. Common gastrointestinal symptoms would include things like cramps, abdominal pain, or vomiting. The third criteria accounts for those patients with involvement of only one organ system. They must have a decrease in blood pressure after exposure to a known allergen for that patient. A decrease in blood pressure is defined as a systolic of less than 90 or a greater than 30% decrease from that patient's baseline blood pressure. Please note that the systolic of less than 90 is not applicable to children less than 11 years old, as their normal blood pressure is age dependent as shown in the table here. It is possible to obtain labs to aid in the diagnosis or confirm the diagnosis of an anaphylactic reaction. However, this is not commonly done in clinical practice as treatment is urgent and cannot wait for laboratory confirmation. Plasma histamine is one possible lab that may be collected. However, it has the downside that levels are elevated very shortly after exposure and only remain elevated for a maximum of 1 hour. So this lab must be drawn within 1 hour of exposure. Another lab test is that for serum tryptase. Ideally, this lab is drawn 15 minutes to 3 hours after exposure, but elevated levels may remain for up to 6 hours. However, if this level is negative, it does not rule out anaphylaxis. It is more of a confirmatory test. There are several other lab tests that can be drawn, but are beyond the scope of this lecture. The skin is by far the most commonly involved organ system in an allergic reaction, although respiratory symptoms are the most publicized and commonly thought of group of symptoms. And there are also gastrointestinal and cardiovascular symptoms that present in a little bit less than half of patients. You will see a correlation between the diagnostic criteria and the most commonly affected organ systems. There are several risk factors for developing an allergic reaction. Gender can play a role, but is specific to the type of allergen. Some examples include that females are more likely to be allergic to quinolone antibiotics and neuromuscular blocking agents than males. Other risk factors for an increased likelihood of an allergic reaction include older age, a prior history of allergic reactions. If you're allergic to one drug, there are likely other unrelated drugs that you will be allergic to, recurrent exposure, and HLA type. Many identified HLA-B alleles show an increased risk of developing an allergic reaction for certain drugs, including carbamazepine, allopurinol, abacavir, and dapsone. Certain disease states make patients more likely to have an allergic reaction, such as leukemia and Epstein-Barr virus, or EBV, increasing the likeliness of an allergic reaction to penicillins. Patients with HIV are more likely to be allergic to sulfonamides due to atypical lymphocytes commonly seen in these patients. More specifically, HIV patients are 10 times more likely to be allergic to sulfamethoxazole, which is problematic as these patients are prone to developing PCP pneumonia, where sulfamethoxazole is a treatment of choice. There are 3 risk factors to identify which patients are more likely to have a fatality due to the allergic reaction. The most important risk factor for fatal anaphylaxis is asthma. Also important to note is the 2 most common drug classes that cause an allergic reaction are penicillins and NSAIDs. However, about 10% of the population claims to have an allergy to penicillin. A study by Salkind and colleagues looked at patients who stated they have an allergy to penicillins and then gave them a skin test to assess whether they actually do have the allergy. 90% of skin tests came back negative. This shows that of every 10 people who say they have a penicillin allergy, it is probable that 9 of them actually don't. It is important to understand that just because you were allergic to something as a small child does not mean you are still allergic to it as an adult. There are many disease states that can present similarly to an allergic reaction, and it is important to be able to distinguish between them. Some of these more frequently seen disease states that present similarly include foreign body aspiration, flushing disorders such as red man syndrome, panic attacks, seizures, and many more. Time until death also varies based on what allergen or substance is causing the allergic reaction. An unknown cause has the least amount of time until death, whereas insect venom, you can have cardiac arrest within 15 minutes. Food, as it takes time to be absorbed in the gastrointestinal tract, will give you at least 30 minutes until cardiac or respiratory arrest. Also, in this table, there are some important food and drug affiliations to remember. However, clevidipine is not yet available in Hong Kong. Treatment can be broken into 2 parts, primary therapy and then secondary therapy. Primary therapy should be done immediately if applicable and available. The first thing to do, obviously, is stop administration of the precipitating agent, primarily applicable in patients who are receiving an intravenous infusion. The second step is to call for help and then administer intramuscular epinephrine or adrenaline. Next, place the patient in a supine position with lower extremities elevated to maintain perfusion of blood to the brain. Maintain the patient's airway and administer 100% oxygen. If blood pressure has dropped significantly, consider intravascular expansion with crystalloid solution. Normal saline is used. Secondary, non-urgent therapy may consist of an H1 antagonist like diphenhydramine, an H2 antagonist like famotidine or ranitidine, catecholamine infusions like dopamine or epinephrine, bronchodilators, primarily salbutamol or albuterol, and you can also consider corticosteroids like methylprednisolone. Which of the following medications listed below is life-saving in anaphylaxis? Epinephrine is the only one proven to decrease mortality, and it has a very profound effect. The mechanism of action of epinephrine is primarily on its effect of three receptors. Alpha-1 agonism leads to vasoconstriction, increased peripheral vascular resistance, and a decrease in mucosal edema. This improves breathing and blood pressure. Beta-1 agonism leads to an increased heart rate and inotrophy, leading to improved blood pressure and perfusion. And beta-2 agonism causes a decrease in the release of inflammatory mediators and an increase in bronchodilation, leading to various symptomatic improvements. The intramuscular route of administration is preferred over the subcutaneous route for epinephrine, as the drug is absorbed faster and more predictably into the systemic vascular system. Speed is essential in this situation. The onset of action of intramuscular epinephrine is less than 5 minutes. It also has a very short half-life. The dose used for an allergic reaction is noticeably less than that used for cardiac arrest, 0.3 milligrams in an allergic reaction versus 1 milligram for cardiac arrest. Please note, the dose for children is weight-based until they reach 30 kilograms. An important point to remember that many people don't realize is that quite often, about 1 in every 3 to 4 patients require a second epinephrine or adrenaline shot. It is important not to leave the patient. Don't send the patient to the hospital without a second epinephrine pen available. Also, for some patients on beta blockers, they may be resistant to epinephrine and develop hypotension and bradycardia. As I mentioned, epinephrine works on both beta-1 and beta-2 receptors. And if both are blocked, you won't see as much effect from epinephrine. Glucagon may be given because it has inotropic and chronotropic effects that are not mediated through the beta receptors. Initial dosing in these patients is listed on the slide and may be repeated in boluses or followed by an infusion. Also important to note is to take caution when rapidly given glucagon, as it commonly causes emesis. After epinephrine is given, the next thing to consider giving is fluids to minimize hypotension. Not all patients need IV fluids. 35% of intravascular volume can leak into the extravascular space in a matter of minutes during an allergic reaction. Normal saline is the preferred intravenous fluid, as lactated ringers can potentially contribute to metabolic acidosis. Distribution of IV fluids is an important concept to understand. This graphic shows that if a liter of each of these 4 fluids is given to a patient, how much of that fluid will actually remain inside the blood vessels. The goal is to keep as much fluid as possible inside the blood vessels. Theoretically, the higher the number in the red box here, the better the outcome for the patient. However, despite the fact that 5% albumin remains in the blood vessels the best, the current literature shows no survival advantage over normal saline or lactated ringers and is significantly more expensive. Therefore, colloid solutions like albumin 5% is not preferred over normal saline and lactated ringers. Glucose 5% in water is not preferred because, as you can see, only 10% remains in the intravascular system. Now, let's talk about other adjunctive agents that can be used during an allergic reaction. H1 antagonists can be used primarily for symptomatic relief of itching and hives. These take much longer than epinephrine to start working, with an average onset of action of over 30 minutes. IV will provide a faster effect than the oral route. There are many H1 antagonists to use, and no one agent is preferred over the other. H2 antagonists are again not life-saving agents. They are just to provide symptomatic relief against urticaria and hives. The two that are commonly used are famotidine and ranitidine. The evidence supporting the use of H1 and H2 antagonists is minimal and very weak. However, due in part to their safety profile, they are commonly used in this situation. Next is the use of bronchodilators, primarily salbutamol. Via nebulization is the preferred route of administration. It is important to note that these drugs cause bronchodilation but do not relieve mucosal edema, as their site of action is smooth muscle cells, not vascular tissue. Glucocorticoids are another adjunctive therapy that you will commonly see utilized. Again, it is important to emphasize that glucocorticoids are not a primary therapy, as their onset of action takes several hours. The reason why glucocorticoids like methylprednisolone are commonly used is that they may prevent biphasic or delayed reactions. No more than 2 days of therapy should be given. About biphasic reactions, they are the recurrence of symptoms after resolution of the initial episode of the allergic reaction. These reactions typically occur within 12 hours of the initial episode, but may recur up to 72 hours later. These type of reactions occur in approximately 15 to 21% of patients. These last 3 slides can be read on your own. No further explanation is really required. It is important when dispensing an epinephrine pen or providing discharge counseling to a patient that these key points are included in your counseling. When recording an allergy in a computer system for a patient, you should ask and document the following features of the reaction. And as always, it is important to ask the patient open-ended questions when interviewing him or her. These are my additional references, and this concludes the first section of the emergency medicine module. Thank you.